Enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome.
In this lecture, we'll be talking about hypertension and drugs used to treat hypertension. So first we need to talk about what hypertension is and why it's so important to treat it. Hypertension is defined as a systolic blood pressure sustained above 140 millimeters mercury or sustained diastolic blood pressure greater than 90 millimeters mercury. So normal blood pressure is less than 120/80, and there's sort of a continuum of disease gradually getting worse and worse and worse. The next category above normal is called pre-hypertension, and that's for blood pressures between 120 to 139 over 80 to 89. And then we get into full-blown hypertension. We have stage 1 hypertension, which is blood pressures of 140 to 159 over 90 to 99. And stage 2 hypertension is anything greater than or equal to 160 over 100. Elevated blood pressure or hypertension is generally caused by increased smooth muscle tone in the peripheral vascular bed, and that leads to increased arteriolar resistance and reduced capacitance of the venous system. The underlying cause for most people with hypertension is unknown. We don't really know what causes this increased vascular tone. But hypertension affects roughly 60 million people in the U.S., so that's about 20% of the population. That's a huge number. And if you start counting the people with pre-hypertension, it's an even larger burden of disease. The other bad thing about hypertension in general is it does not cause a lot of symptoms. Most people are asymptomatic. They don't feel bad. They don't feel like they have high blood pressure. They don't even want to believe that they really have high blood pressure. Let's talk about the etiology of hypertension. As I mentioned, more than 90% of patients have essential hypertension, which is where we don't know what causes that increased vascular resistance. The other 10% of patients have secondary hypertension, and it's usually secondary to renal disease in one form or another, either chronic renal failure or renal artery stenosis. There are several risk factors for hypertension that are important to know about because you can ask your patients whether or not they have any of these risk factors. First of all is family history or genetics. Race is an important risk factor. Blacks have a higher incidence of whites by about 400% higher, and Asians have an even lower incidence of hypertension. Sex is a risk factor. Males are more likely to have hypertension than females. We know that hypertension and cardiovascular disease in general are very common in women, but they're even more common in men. Age is a risk factor for hypertension. The incidence of hypertension rises as we get older. It's felt that the blood vessels are becoming stiffer and less compliant, and therefore the blood pressure rises. Obesity and being overweight carry an increased risk of hypertension, as do diabetes and the metabolic syndrome. These things all go together. Having a stressful lifestyle will increase your blood pressure. Having a high sodium intake in your diet will increase your blood pressure, and then smoking will certainly increase your blood pressure as that contributes to atherosclerosis and stiffening of the blood vessels. Hypertension also predisposes people to a lot of other diseases, and so even though these patients are asymptomatic and they feel fine, the elevated blood pressure is doing damage in the body. It causes an increased risk of atherosclerosis, so cardiovascular disease in one form or another. It causes an increased risk of left ventricular hypertrophy. Specifically, the left ventricle is pumping blood against a higher afterload. And so it's having to work harder, and so the left ventricular myocytes are becoming hypertrophied, thickened, fibrotic, and the left ventricle is more likely to then go into left ventricular failure, congestive heart failure. Hypertension increases the risk of stroke dramatically, both ischemic or thrombotic stroke, where you have atherosclerosis of the cerebral vessels, and then also hemorrhagic stroke if you have an aneurysm. If the blood pressure is elevated, it's more likely to rupture and cause a hemorrhagic stroke. Hypertension does damage to blood vessels in the kidneys, and so you can have renal failure and glomerular sclerosis and that sort of thing. You can have retinopathy or damage to the blood vessels and the vasculature of the retina, and you can have aortic dissection as a complication of hypertension. So hypertension carries a lot of risks in itself, and even though it's asymptomatic, it's important to identify and treat early. We know that by lowering even moderately elevated blood pressure will really significantly reduce the incidence of cardiovascular disease in those patients, and we know that you can reduce morbidity from both cardiovascular disease and renal disease by identifying that hypertension early and getting it appropriately treated. So there are a lot of physiologic mechanisms that the body uses to control the blood pressure under normal circumstances. The body needs to maintain a balance between adequately perfusing tissues, so you need to have enough blood pressure to perfuse the vital organs, and getting too much perfusion or too much blood pressure, which causes end organ damage and vascular damage and endothelial damage. So arterial blood pressure is directly proportional to the mathematical product or the multiplication of cardiac output and peripheral vascular resistance. Most antihypertensive drugs are going to affect either the cardiac output by reducing heart rate, reducing contractility, reducing the blood volume, or they're going to affect the peripheral vascular resistance. And there are two overlapping control mechanisms that the body uses to control these two factors. There are the baroreflexes and the pressure sensors, the baroreceptors in the body, and those are mediated by the sympathetic nervous system. And then there's also the renin, angiotensin, aldosterone system, which is very important for long-term blood pressure control. So we'll talk about each of these in turn. First, talking about the baroreceptors in the sympathetic nervous system. These are responsible for the rapid moment-to-moment alterations in blood pressure. You're lying down for a long period of time, you stand up quickly, what happens? Your blood pressure drops, and your body senses that, and it causes vasoconstriction to increase the blood pressure and increase resistance so you can perfuse your brain. Because when you feel lightheaded and dizzy, when you stand up too quickly, it's because your brain's not getting enough oxygen, it's not getting enough blood. The other system to talk about is the renin, angiotensin, aldosterone system, which is responsible for the long-term control of the blood pressure, and it operates by altering the blood volume. So there's an enzyme called renin that's released by the kidneys in response to three things. First of all, the kidneys are going to sense the blood pressure. There are baroreceptors in the kidneys that sense the blood pressure, and if the blood pressure is lower, renin is going to be released. The sympathetic nervous system also stimulates adrenergic receptors in the kidneys, which stimulate renin release. And then finally, if there's sodium loss or low sodium intake, the kidneys are going to sense that and release more renin in order to help the body retain more sodium and therefore retain more fluid. So renin is an enzyme that cleaves a peptide called angiotensinogen into angiotensin 1. And then another enzyme called angiotensin converting enzyme comes in and converts that angiotensin 1 to angiotensin 2. Now angiotensin 2 has two actions. First of all, it is a potent vasoconstrictor. It's one of the most potent vasoconstrictors in the entire human body. Second, angiotensin 2 stimulates production of aldosterone in the adrenal cortex. The zona glomerulosa in the adrenal cortex produces aldosterone in response to stimulation from angiotensin 2. And the action of aldosterone is to retain sodium, retain water, and increase the blood volume. And therefore, it increases the blood pressure. So let's talk about some ways that we can alter the blood pressure, some treatment strategies. First of all, there are lots of classes of drugs we can choose from. These are not individual drugs, these are just classes of drugs. So there are the diuretics, the beta blockers, ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, alpha blockers, vasodilators. And within each of these classes there may be half a dozen or more drugs. So there are lots and lots of options out there for controlling blood pressure. Sometimes, if you have a patient with mild hypertension, you might be able to control their blood pressure with just one drug. But more often than not, you need to use more than one drug, and specifically more than one class of drugs is required. The current recommendations are that you start with a thiazide diuretic, and we'll talk about why those recommendations are in place. If there are strong indications to use another drug, you may start with something else, but thiazides are almost always the first drug you reach for. And then if the blood pressure is inadequately controlled with that first-line drug, instead of ratcheting up the dose or switching off of that to something else, you may want to add a second class, and sometimes patients need 3 or 4 different classes of drugs. It's often more effective to add a different drug rather than to maximize the dose of the first drug you start. Often when you maximize the dose of the first drug, you're going to get more and more side effects and more toxicity from that drug. And many pills are sold as fixed dose combinations of 2 or even 3 different blood pressure drugs together in one pill, which improves compliance because the patient can just take one pill. It's very frustrating to a patient when you finally convince them that they have high blood pressure and they need to be on medication, and you put them on a pill and say, come back in 2 weeks, or come back in a month, and they come back and the blood pressure is still not controlled, what do? You're throwing another pill at them. They don't like that. Before long, they begin to think of you as just a pill pusher. And so what you really have to do is find the right combination of drugs, and hopefully you can find a combination that is in a fixed dose combination with 2 or 3 drugs together in the same pill. You also have to think about the patient's specific disease processes and their demographics in order to individualize the care that you're going to provide this patient. For instance, black patients respond better to diuretics and calcium channel blockers than they do to beta blockers and ACE inhibitors. So you may want to reach for a certain drug based on a patient's race. You also may want to reach for a certain drug based on a patient's age. Elderly patients often respond very well to calcium channel blockers and ACE inhibitors and diuretics, but they don't tolerate beta blockers and alpha blockers as well. So you have to individualize care a little bit. You also want to look at the patient's comorbid conditions. Take a good history and find out what other disease processes they have. For instance, if a patient has coronary disease or angina, you want to put them on a beta blocker. You need to put them on an ACE inhibitor. Those are drugs that they need for their coronary disease regardless of what their blood pressure is. And if you can use those drugs to also treat their blood pressure, you'll be doing the patient a real favor. Maybe they have angina and you want to put them on a calcium channel blocker because that's also going to help with their angina. If the patient has diabetes, you often want to put them on an ACE inhibitor or an angiotensin receptor blocker, or sometimes a diuretic, and we'll talk about the reasons why in a moment. If the patient has chronic renal disease, they often will benefit from an ACE inhibitor or an angiotensin receptor blocker anyway, so again, you can treat their hypertension with that. Patients with congestive heart failure often need several of these classes of drugs anyway. They need diuretics, they need an ACE inhibitor, they need a beta blocker. So you need to take into consideration the patient's other disease processes when you're choosing a drug. You also need to consider patient compliance when choosing antihypertensive therapy. As we mentioned, hypertension is generally an asymptomatic disease process for a long time, and so patients are often poorly motivated to take a pill. Why should I take a pill when I'm feeling fine? The pill's not going to make me feel any better. Also, these drugs often have adverse effects, and the adverse effects may be more problematic than the fact that they have hypertension. In the patient's mind, why should I take a drug that's going to make me feel bad on the off chance that I might get a heart attack or a stroke 20 years from now? And that's not entirely unreasonable, but we need to find drugs that are going to minimize adverse effects and help the patients comply with the prescribed therapy. And one other thing before we get into the pharmacotherapy, and that is that there are some things you can do with your patients to lower their blood pressure without drugs, namely diet, exercise, and weight loss. Those things will help lower cholesterol, they'll help lower the patient's weight, they'll help lower the patient's risk of heart disease. So if we could get our patients to lose weight and eat better and exercise, we could eradicate a lot of these problems. So let's talk next about diuretics. It's our first class of drugs. Now, there's an entire chapter in your Lippincott's text on diuretics, chapter 22. We have an entire lecture in the DIT pharmacology course on diuretics. So I'm not going to go into a lot of details here. But let's talk about the basics of diuretics, because as I mentioned, thiazide diuretics are generally a first-line drug for hypertension, so it's appropriate to talk about them briefly. The 3 classes of diuretics that we use in hypertension are the thiazides, the loop diuretics, and the potassium-sparing diuretics. In general, low-dose diuretic therapy is safe, it's inexpensive, and it does reduce morbidity and mortality, as we'll see shortly. So first, the thiazide diuretics. The drugs we're talking about are hydrochlorothiazide, which is by far the most common thiazide used, and then also chlorthalidone. Thiazide diuretics act by increasing sodium and water excretion, which leads to a decrease in extracellular volume, and therefore a decrease in cardiac output and renal blood flow. So as I mentioned, these drugs are often used first line for the treatment of hypertension. There was a study called the Antihypertensive and Lipid-Lowering Treatment to Prevent Heart Attack Trial, or ALLHAT. If you haven't heard of the ALLHAT trial, you will hear of it frequently, so you should be familiar with these findings. This was a huge trial, about 42,000 patients with hypertension, and they found that if you gave a thiazide diuretic, you could lower the incidence of stroke and other cardiovascular endpoints by 10 or 15% more than if you gave an ACE inhibitor or a beta blocker or a calcium channel blocker. The catch is that the thiazide that they used in the ALLHAT study was not hydrochlorothiazide, which is the drug everybody uses anyway. It was chlorthalidone. So a lot of people say, well, this was probably a class effect, and I'm going to extrapolate and say that hydrochlorothiazide is going to be more beneficial because we know chlorthalidone was more beneficial. But there are some experts who say, look, we ought to be using chlorthalidone rather than hydrochlorothiazide. Thiazides, specifically hydrochlorothiazide, or HCTZ as it's commonly called, are often used in combination with other drugs because they counteract the sodium and water retention that some other drugs can cause. Thiazides are particularly useful in treating hypertension in the elderly and in blacks, as we mentioned. They're not generally effective in patients who have poor kidney function. So if the creatinine clearance is less than 50 milliliters per minute, thiazides may not do much for you. The pharmacokinetics, the absorption and elimination rates vary widely from drug to drug. So we're not going to get into too much of that, but I will say that thiazides can compete with uric acid for elimination. So uric acid levels may be elevated, and that can lead to gout. Which brings us to the adverse effects of thiazides. So the main adverse effect that you're going to see, and the one you need to know the most about, are electrolyte disturbances. You can get hypokalemia, or low potassium. You can get hyperuricemia, or high uric acid levels, in up to 70% of patients. So hypokalemia, very common. Hyperuricemia is relatively common. Hyponatremia, or low sodium, can be very common, especially in patients who have other predisposing factors to hyponatremia. If you put them on a thiazide, it may exacerbate that. Thiazides will decrease the urinary excretion of calcium, so you may have more calcium retained, and therefore you may have mild hypercalcemia. You can get low magnesium or hypomagnesemia. You can get hyperglycemia or elevated blood sugar in about 10% of patients. So if you're putting a diabetic patient on thiazide, you need to at least be aware of that and watch the blood sugar very carefully. And patients who are sensitive to sulfa drugs can be sensitive to thiazides because thiazides are sulfa drugs. So that's not to say that everyone who ever had an allergic reaction to the antibiotic sulfamethoxazole is definitely going to have a reaction to their hydrochlorothiazide, but it could happen, so you need to be aware of that. The next category of diuretics to talk about are the loop diuretics, which include furosemide, bumetanide, and torsemide. These drugs are going to decrease renal vascular resistance and increase renal blood flow, which is a good thing. You're actually perfusing the kidneys a little bit better when you use these diuretics. These drugs work quickly. They act very promptly, even in patients with poor renal perfusion or poor renal function. Even if they haven't responded to other diuretics, you can give them a loop diuretic and get a good response. So we often give patients with congestive heart failure or even renal failure diuretics to promote a diuresis. The duration of action of loop diuretics is relatively brief. It's 2 hours to 6 hours. The drug furosemide has a brand name Lasix. You can remember that because it lasts 6 hours. So sometimes these drugs have to be dosed 2 and 3 and 4 times a day, especially in hospitalization settings. The adverse effects of loop diuretics, again, they're going to mess with your electrolytes. They're going to cause hypokalemia, they're going to cause hyperuricemia, they're going to cause hypomagnesemia. They're less likely to cause the hyponatremia, which is a good thing. Now, loops cause you to lose calcium. Loops lose calcium, so you'll have increased urinary calcium excretion, so you should not get hypercalcemia. You don't usually see hypocalcemia with loop diuretics, but you might see kidney stones formed from all that calcium being forced into the urine. And rarely you can get ototoxicity or hearing loss, ear damage, from loop diuretics, especially if you're giving the loop diuretic in conjunction with an aminoglycoside antibiotic. So be aware of that, especially for your testing purposes. Loop diuretics can cause ototoxicity, but relatively rare. The last group of diuretics I want to talk about are the potassium-sparing diuretics. These include spironolactone, triamterene, amiloride, and eplerenone. Now, just briefly, eplerenone is used more for patients after they've had an MI than it is just strictly for hypertension, but it is a potassium-sparing diuretic. These drugs are lumped together not based on their mechanism of action, but rather based on the effect. They don't cause hypokalemia. They don't cause you to lose potassium. They are potassium-sparing. Amiloride and triamterene inhibit sodium transport at the distal collecting tubule and the collecting ducts. Spironolactone and eplerenone are both antagonists of the aldosterone receptor. All of these will reduce potassium loss in the urine. The adverse effects, spironolactone is one of the most common ones that we use. It can cause gynecomastia, menstrual irregularities, and hyperkalemia. Triamterene can cause leg cramps, hyperuricemia, and hyperkalemia. The unifying theme there is hyperkalemia. If you're giving something that is not going to make you lose potassium, you may get hyperkalemia, so you need to be careful with that.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
Alice, you here?
Do you always interrupt people so rudely when they're in the middle of dinner?
Look, I need your help. We have an older female patient who came in earlier which looked like she had a severe panic attack, excessive sweating, and increased heart rate. Only now she has elevated blood glucose, a pounding headache, and her blood pressure is through the roof.
Well, you've done a bang-up job over there, doll-face. One question, though. Why is this my problem?
I heard you're going particularly fond of the pudding we serve at the hospital. Might be a few in it for you if you help me.
Are we talking banana? Make it 3 and you've got yourself a deal. People I could care less about. A banana pudding, that is a different story. Alright, check the urine for catecholamines. What your patient has is pheochromocytoma. That needs to be checked, of course, but first you need to control the blood pressure using phenoxybenzamine, an alpha blocker, and plenty of IV saline to correct the volume depletion.
Thank you. You really saved me on this one.
Hey, what about my pudding?
So now let's go through the answers to quick review 1. Number 1, what lifestyle modifications should every patient with hypertension make? This is very important to understand because we don't always treat hypertension with medications initially, right? And it's very important to counsel patients on other things that they can be doing to control their hypertension outside of pharmaceuticals. So I think it's definitely important to know this. So just 4 main things I want you to know for this answer. Number 1, smoking cessation to decrease MI risk is very important. Number 2, weight loss. One of the things you'll see clinically is even a small loss of weight can make a big difference in blood pressure control. So sometimes just having the patient lose 10 pounds can dramatically decrease their systolic and diastolic blood pressure. Low sodium diet is the third one. It's very important for patients to try a low sodium diet, and for about 50% of patients this is helpful in controlling their blood pressure, but for the other 50% that have essential hypertension, it's not helpful. And then the fourth thing I want you to know in counseling these patients is what's called the DASH diet. DASH, D-A-S-H, stands for the dietary approach to stop hypertension. And the short version of this diet essentially is that they need to have at least 4 fruits a day, at least 4 vegetables a day, and 3 servings of low-fat dairy a day, in addition to reducing their sodium intake. So that's the DASH diet. If you're going to be treating hypertensive patients, you should become familiar with that. Number 2, what are the 4 common reasons for hyponatremia, low sodium? So we mentioned low sodium earlier on in the lecture, and I thought I'd just introduce you guys to some of the things that might cause hyponatremia. There's a big algorithm for hyponatremia that depends upon the volume status of the patient, and if you want to look really impressive on your internal medicine rotation, I would recommend that you memorize that algorithm. But today, I just want you guys to know 4. So it's just an introduction to hyponatremia. 4 main things cause it. Diuretics can cause hyponatremia, we mentioned that earlier. Congestive heart failure is another big cause of hyponatremia. Cirrhosis can cause hyponatremia, and renal failure can cause hyponatremia. So heart failure, kidney failure, liver failure, and diuretics can all cause hyponatremia. That's worth knowing. Number 3, what class of diuretic is actually useful in treating patients with hyponatremia? These are loop diuretics. So when you think of loop diuretics, think about a very potent diuretic that allows you to lose free water. So sometimes hyponatremia is due to an excess amount of free water diluting the sodium. So if you can get rid of some of that free water, it's going to bring your sodium level back into the normal range. So loop diuretics here. Number 4, in what scenario would you choose a thiazide as the antihypertensive of choice? So there's lots of reasons to choose a thiazide diuretic, such as hydrochlorothiazide. I'm going to give you 6. Number 1, if you have a patient with essential hypertension and no other comorbidities, hydrochlorothiazide or other thiazide is a great first-line diuretic. It's usually going to be your first go-to medication. It's inexpensive and very effective. Number 2, black patients are particularly sensitive to thiazide diuretics, so they're great drugs for black patients to use. Number 3, elderly patients might benefit from a thiazide if they have hypertension. Number 4, mild heart failure is another indication for thiazides. Now, if you have moderate to severe heart failure, usually you're going to go for the loop diuretic, not the thiazide. But for mild heart failure, you might consider a thiazide. The next one is hypercalciuria. If you have too much calcium in your urine, you might use a thiazide to maintain calcium in your serum and excrete less of it into your urine. So the mnemonic I use for this is loops lose calcium, thiazides don't. So thiazides retain calcium. And then the 6th indication for thiazide is diabetes insipidus. We're not going to get into why that is, but if you want to treat diabetes insipidus, your drug of choice is going to be a thiazide diuretic. Number 5, which drug category, if used in combination with loop diuretics, may cause ototoxicity? Just a high yield, little important thing to know. These are aminoglycoside antibiotics. Number 6, what is the mechanism of action of the following antihypertensive diuretics? Highly testable. So thiazides, they decrease the reabsorption of sodium in the distal tubule. So this results in more sodium chloride going into the urine. And where sodium and chloride go, water follows. And so that's why this is a diuretic. But of course, because you're losing sodium in the urine, it can cause hyponatremia. Your loop diuretics, specifically, their mechanism is to inhibit the sodium-potassium chloride symporter, or sodium-potassium chloride co-transporter, in the ascending loop of Henle. So that's worth knowing. Amiloride and triamterene inhibit sodium transport in the late distal tubule and the collecting ducts as well of the nephron. So they inhibit sodium transport in the late distal tubule and collecting ducts of the nephron. And then the last 2, spironolactone and eplerenone. These are aldosterone receptor antagonists. So those last 2 rows are both potassium-sparing diuretics, but the mechanism of amiloride and triamterene is slightly different than that of spironolactone and eplerenone. Number 7, why does spironolactone have gynecomastia as a side effect? It chemically resembles some of the sex steroids, and as a result can cause gynecomastia, and it's actually a very common side effect in males. Number 8, what is the diuretic of choice in patients with renal failure, specifically when the creatinine clearance is below 50 mLs per minute? These are loop diuretics. Thiazides can be used in early renal failure. However, at some point, the thiazide is not going to be as effective as the loop diuretics. And at some point in very, very severe renal failure, even the loop diuretics start working. And then what do those patients need? Dialysis. So you go from a low-dose loop to higher dose loop to dialysis eventually. Possibly you would use thiazides very early on, but loops usually are your drug of choice for renal failure patients. If you have a patient with renal failure and they're not making urine and you want them to make urine, you can try a loop diuretic. If that's not working, probably going to need dialysis. Number 9, what is the maximum dose of hydrochlorothiazide, or HCTZ, that should be used to optimize blood pressure control and minimize side effects? This is a huge clinical pearl that you're not going to see in a lot of books. Hydrochlorothiazide typically is dosed at either 12.5 milligrams or 25 milligrams. Beyond 25 milligrams of hydrochlorothiazide, there's no additional blood pressure control effect, but you do have an increased risk of side effects, such as increasing uric acid and causing gout. So beyond 25 milligrams, there's no reason any patient needs to be taking more than 25 milligrams of hydrochlorothiazide on a daily basis. So it's either 12.5 milligrams or 25 milligrams that we dose. And there's one more thing I want to discuss before we finish this quick review. If you go back to earlier on in the lecture when we were talking about the preferred antihypertensive based on specific patient characteristics or disease states, there is a table in your study guide. A few things I want to point out of that table. I like to categorize these disease states or patient characteristics based on major criteria and minor criteria. Because what if you have a patient that has congestive heart failure, that's black, that's elderly? I mean, how are you going to choose which antihypertensive to use? Well, you're going to refer to your major criteria first, your major considerations. And those are the bottom 4 there on that table. So coronary artery disease, diabetes, chronic renal disease, and congestive heart failure are going to trump any other patient considerations. So that should be the first consideration that you have. So coronary artery disease, these patients definitely need to be on a beta blocker and an ACE inhibitor to reduce their risk of morbidity and mortality. Beyond that, if you need additional control, you can use a calcium channel blocker or you can use a hydrochlorothiazide. But the first 2 to go for are beta blockers and ACE inhibitors. If they can't use an ACE inhibitor, what can they use? An angiotensin receptor blocker, an ARB. Diabetic patients, we've talked about. Chronic renal disease, we've talked about. So you can use ACE inhibitors or ARBs to reduce the progression of proteinuria in renal disease. The main thing here is if you have renal disease to such an extent that you're having a hard time getting rid of potassium, because kidney failure patients have a hard time excreting potassium, you might get hyperkalemia. And of course, if you have hyperkalemia, you can't use either of these 2 drugs, and you're done with ACE inhibitors and ARBs in that patient. Congestive heart failure, again, to reduce morbidity and mortality, you need a beta blocker, and you need an ACE inhibitor or an ARB. If they're building up water, then a loop diuretic would be useful also, but loop diuretics, ironically enough, or strangely enough, do not reduce morbidity or mortality, but of course they do make the patient more comfortable. And then one other drug category to consider here is that your aldosterone antagonists, such as spironolactone, actually also reduce morbidity and mortality. So you're going to want to add a low dose of that also. So the 3 go-to for congestive heart failure: ACE inhibitors or ARBs, beta blockers, and then spironolactone, and then for symptom control you can use a loop diuretic as well. So those are your 4 major considerations. Being black is a consideration when choosing an antihypertensive. Diuretics work well for black patients. Calcium channel blockers work well for black patients. Labetalol also works well for black patients. In elderly patients, you have calcium channel blockers, ACE inhibitors. Diuretics are preferred over beta blockers, and also alpha blockers, alpha blockers. A couple other minor considerations here that I want you to think about. If you have a postmenopausal female or a patient with osteoporosis, a hydrochlorothiazide or thiazide diuretic, which is going to retain calcium and help reduce the excretion of calcium, is actually going to reduce the progression of your osteoporosis. That's something to consider. If you have a postmenopausal female or an osteoporotic patient with hypertension, you might reach for the thiazide. If you have a patient with migraines, or a patient with a benign essential tremor, or a patient with anxiety, what are you going to reach for in those circumstances? A beta blocker might be helpful, right? So beta blockers are going to reduce the incidence of all 3 of those. Beta blockers are one of the drugs that can be used for migraine prophylaxis. If you have a patient with stroke, this might be more of a major consideration. Patient with a history of stroke, hydrochlorothiazide, and also ACE inhibitors and ARBs have been shown to reduce the recurrence of strokes. So that's something you definitely want to consider also. And then the last consideration I want you to throw in there is a patient with BPH, with benign prostatic hyperplasia. You can reach for an alpha blocker that's going to help the flow of urine in those patients as well as reduce hypertension in those patients.
The next category of drugs we'll talk about are the beta blockers, or the beta adrenoreceptor blocking agents. These include the drugs propranolol, atenolol, metoprolol, nadolol, timolol, bisoprolol, nebivolol. We'll talk about carvedilol and labetalol later. Now all these end with OLOL, or all. So that's the way you can remember that these are all beta blockers. They all have the same ending. Beta blockers are discussed in other chapters. Chapter 7 is all about adrenergic antagonists, so that's the one where you'll find the main information about beta blockers. They're also discussed in Chapter 16 on heart failure and in Chapter 17 on antiarrhythmics. But we'll be talking about the agents that are used primarily for hypertension in this section. So the action of beta blockers, they reduce blood pressure primarily by decreasing cardiac output. They're going to reduce heart rate, they're going to reduce myocardial contractility, so you're going to have decreased cardiac output. They may also decrease the sympathetic outflow from the central nervous system and therefore inhibit the release of renin, because remember, the sympathetics trigger the release of renin. They stimulate renin release from the kidneys. Now we need to think about selective beta blockers versus non-selective beta blockers. The prototype beta blocker is propranolol. It's a drug that's been around for a long time, and it acts both at the beta 1 and beta 2 receptors. So we say it is non-selective. It just blocks all the beta receptors. Because it can block the beta 2 receptors, it can provoke some bronchospasm. So you have to use caution in using a non-selective beta blocker in a patient who has lung disease, such as asthma or COPD. The other drugs, such as betaxolol, esmolol, atenolol, and metoprolol, are called beta 1 selective beta receptors, or sometimes they're called cardioselective because they just act on the beta 1 receptors in the heart. They can be used in patients with asthma. You just have to use a little caution because if you get to a high dose, if you get to too high a dose, you can get some beta 2 blockade with these cardioselective drugs. Now, betaxolol is used primarily to treat glaucoma, and esmolol is primarily used as an antiarrhythmic drug. The two selective beta blockers that are used most commonly for antihypertension are atenolol and metoprolol. So, as we mentioned, beta blockers are more useful in whites than they are in blacks. They're better tolerated in young patients than they are in elderly patients. We often use them in hypertensive patients who have other diseases such as tachyarrhythmias or supraventricular tachycardia. You can actually suppress those arrhythmias with the beta blocker. You can suppress palpitations. As I mentioned, patients with coronary disease or angina may benefit from a beta blocker. Patients with chronic heart failure can benefit from a beta blocker, but you don't want to ever start a beta blocker in a patient who has acute congestive heart failure because that suppresses myocardial contractility and is going to make things worse. We also use beta blockers for a lot of non-cardiovascular indications. I mentioned glaucoma, treatment of migraine or prevention of migraine sometimes. Patients with certain types of tremor, essential tremor, can respond to beta blockers. Patients with social anxiety, such as stage fright, actors, musicians who have to get up on stage and get a lot of sympathetic discharge will be put on beta blockers to use when they're going out on stage to help reduce the stage fright. The pharmacokinetics of beta blockers are relatively straightforward. These are all oral drugs. There are a few of them that are used IV, but for the most part when we're talking about treating hypertension, we're talking about oral drugs. The half-lives are usually pretty short, anywhere from 4 to 6 hours, so often you have to give these drugs twice a day. But there are extended release versions of metoprolol and other drugs that are available. Beta blockers may take several weeks to take effect, so you need to be aware of that. Propranolol is extensively metabolized by the liver using first-pass metabolism. Atenolol is extensively excreted by the kidneys, almost 100% renally excreted. So if you have a patient with liver disease, you probably don't want to put them on propranolol. You might want to use atenolol. Metoprolol has both hepatic metabolism and then renal excretion, so it's a little safer for all patients. As far as adverse effects, we mentioned that beta blockers are going to reduce the heart rate. They can actually reduce the heart rate too much and cause bradycardia. They can cause some neurological symptoms of fatigue and lethargy, usually for the first few days when you put a patient on a beta blocker or you titrate up the dose. The patient's going to feel pretty crummy. They're going to feel pretty run down. And I usually warn patients, look, this is going to make you feel bad for a couple days. Stick with it, and if you're still feeling bad a week from now, we can talk about whether or not we need to back off on the dose or stop the drug. Sometimes beta blockers can cause some insomnia. Rarely they can cause some hallucinations, but fatigue is much more common. Beta blockers can trigger arrhythmias. If you stop a beta blocker quickly, you can theoretically precipitate cardiac arrhythmias, which could be severe, so it's recommended that we taper off over 7 to 10 days. If you treat long-term with a beta blocker, you can actually have upregulation of the beta receptors, and then when you stop the drug, you have a lot of beta receptors there, and so you're going to trigger some arrhythmias. It can also worsen angina and hypertension because of the upregulation of the beta receptors. As we mentioned, non-selective beta blockers such as propranolol can cause bronchoconstriction and bronchospasm, so you need to be very cautious. You need to avoid those drugs in patients with asthma, and you'd be very cautious if you're using a cardioselective beta blocker. You can still use them, you just need to be careful. Beta blockers tend to cause some sexual impairment. It's not really clear why, but a lot of men who are put on beta blockers will complain of erectile dysfunction and loss of libido. It's pretty clear that cardiovascular disease in general and specifically hypertension are both risk factors for erectile dysfunction, so it may be that we're just unmasking a previously existent disease by adding a beta blocker. Also, erectile dysfunction may limit patients' compliance. If they were feeling pretty good and you tell them they've got high blood pressure and you put them on a beta blocker, now all of a sudden they're no longer able to get an erection, they're going to be pretty upset and they're not going to keep taking the drug. So be aware of that. Beta blockers also cause significant disturbances in metabolism. They decrease glycogenolysis and they decrease glucagon secretion, so they can cause hypoglycemia. You can get fasting hypoglycemia. So if you have a diabetic patient, you're putting them on a beta blocker, you need to be aware of that and need to watch closely for any big changes in the blood sugar. If you've got them on a drug such as insulin or sulfonylurea that's going to increase the risk of hypoglycemia, you need to really be cautious. Beta blockers can also decrease HDL, or that's the good cholesterol, and they can increase triglycerides. So a lot of these patients will already have some dyslipidemia, and you could potentially make it worse with your beta blocker. So you need to be monitoring this. The next group of drugs I want to cover are the ACE inhibitors. And these are also covered in Chapter 16 on heart failure, because these drugs are widely used for heart failure and for patients with coronary disease. We already talked about the renin-angiotensin-aldosterone system, and now we're going to talk about how we can manipulate that system to lower blood pressure. The drugs specifically we're talking about for ACE inhibitors are captopril, enalapril, fosinapril, lisinopril, quinapril, and ramipril. So ACE inhibitors are going to inhibit angiotensin-converting enzyme, or ACE. The action of angiotensin-converting enzyme, as you remember, is to cleave angiotensin 1 to angiotensin 2. Angiotensin-converting enzyme also inactivates or degrades a chemical called bradykinin, which is a vasodilator. So if you have less angiotensin 2, you're going to have less vasoconstriction. If you have more bradykinin, you're going to have more vasodilation. Now, there are two other enzymes that inactivate bradykinin, which are still around, but the angiotensin-converting enzyme does play a role in inactivating bradykinin, so you do have an increase in bradykinin, which helps lower the blood pressure. And overall, you're having decreased vascular resistance, so decreased afterload, and you're also going to have decreased venous tone, so decreased preload. So you have lower blood pressure because of both of these effects. So ACE inhibitors affect both venous and arterial vasculature. A lot of these drugs affect only one or the other. So as we're looking at the different drugs that act on the vascular system, be aware that ACE inhibitors and angiotensin receptor blockers will affect both arterial and venous vasculature. So we use these drugs in the treatment of hypertension. ACE inhibitors are generally most effective in patients who are white and patients who are young, but they work on lots of people, so they're used widely. They're often used in combination with the diuretic because that actually enhances the effectiveness of ACE inhibitors. We use them, as I mentioned, in congestive heart failure. We use them in patients who have had an MI to reduce cardiac remodeling. We use them in patients with renal disease to reduce proteinuria, and patients with diabetic nephropathy to reduce proteinuria. We want to avoid ACE inhibitors in patients who have renal artery stenosis because ACE inhibitors prevent the efferent arterioles from constricting. So remember the structure of the glomerulus. You have an afferent arteriole bringing blood into the glomerulus and an efferent arteriole taking blood away from the glomerulus. Now in renal artery stenosis, afferent blood flow is reduced and there's very little blood trickling in. The body's response to that is to constrict those efferent arterioles so that the blood flow out of the glomerulus matches the blood flowing in, so you can maintain a reasonably good glomerular filtration rate, or GFR. But if you give an ACE inhibitor to a patient with renal artery stenosis, the efferent arteriolar system cannot constrict. The blood is being taken away by the efferent arterioles faster than it can be delivered, and the GFR is reduced. So in a patient with renal artery stenosis, you want to avoid using an ACE inhibitor. The pharmacokinetics, these are oral drugs. If you give them with food, it may delay absorption. So often we tell patients to take these on an empty stomach. Most of these drugs require hydrolysis in the liver in order to become active, and most of them are renally excreted. The half-life is generally anywhere from 2 to 12 hours, so a lot of these drugs have to be dosed twice a day, but some of the newer ACE inhibitors can be dosed once a day. The adverse effects of ACE inhibitors are very important to know and very common because we use these drugs a lot, so we see the side effects a lot. One of the most common side effects is a persistent, dry, nagging cough. It's not dangerous, but it's bothersome to the patient. It's thought that the increased levels of bradykinin somehow trigger this cough. Another more dangerous, or more potentially dangerous adverse effect of ACE inhibitors is hyperkalemia, or elevated potassium, and then renal insufficiency. So you need to monitor the patient's potassium, you need to monitor the patient's creatinine and BUN. ACE inhibitors can rarely cause a potentially life-threatening condition called angioedema, which is where you have increased permeability of the vascular supply of the lips, the tongue, the mouth, the oral mucosa, anywhere from the lips to the larynx, basically. So you get massive swelling of this tissue. This can cause airway compromise, it can cause asphyxiation, so it's an emergency. If you see a patient with angioedema from an ACE inhibitor, you need to hospitalize them and monitor them very carefully to make sure they don't get any airway compromise. Often we treat this by, first of all, stopping the ACE inhibitor. We treat this by giving epinephrine and antihistamines and usually a glucocorticoid, although there's not a lot of data to support this regimen, but in theory it should work, so we do it. You always have to stop the offending drug if it's causing angioedema, and we consider this a class effect. So if they had angioedema from one ACE inhibitor, you're going to assume all ACE inhibitors are off limits. Angioedema is generally more common in blacks than in whites, so that's worth knowing and worth communicating to your patients. I usually tell patients about angioedema, tell them to watch for it. I tell them it's very rare, but they need to know that it's a real potentially dangerous side effect, so that if they get even the beginnings of angioedema, they call me right away and they come right in. ACE inhibitors are also contraindicated in pregnancy. They can cause kidney damage to the fetus, so they act on the kidneys in the mother, but they're dangerous to the fetus's kidneys. So don't ever give an ACE inhibitor or an angiotensin receptor blocker to a pregnant woman. The next group of drugs we'll discuss also act on the renin-angiotensin-aldosterone system, and these are the angiotensin receptor blockers, or ARBs. These are also covered in Chapter 16 on heart failure. The drugs are losartan, candesartan, valsartan, telmisartan, irbesartan, and olmesartan. So these drugs are competitive antagonists of the angiotensin II type 1 receptors. There's type 1, type 2, type 3 receptors, but they're all receptors for angiotensin II. So if you're blocking those receptors, you're blocking the actions of angiotensin II, which are vasoconstriction and stimulation of release of aldosterone. The ARBs do not affect bradykinin levels, so you shouldn't have an elevated bradykinin, you shouldn't have a cough, as you got from the ACE inhibitor. Very often we'll use ARBs in patients who need an ACE inhibitor but couldn't tolerate one because of cough or other side effects. Elevated bradykinin is also thought to play a role in causing the angioedema we talked about with ACE inhibitors, so theoretically ARBs should not cause angioedema. We use these drugs in hypertension. We also use them in congestive heart failure and in patients who have had an MI, just like we used ACE inhibitors. We often use ARBs for patients with renal disease who cannot tolerate ACE inhibitors. These drugs are administered orally. They're given once a day. Losartan undergoes first-pass hepatic metabolism to its active metabolite, so it's technically a prodrug. The others don't have to go through that. They're active as taken. The adverse effects of ARBs are very similar to ACE inhibitors, except you have a much lower risk of cough. You can still get some hyperkalemia and from renal insufficiency, so you still need to monitor labs. Theoretically, the risk of angioedema is lower, as I mentioned, but there are some reports of patients who got angioedema from an ARB. So generally, personally, if I have a patient who had angioedema from an ACE inhibitor, I'm not comfortable putting them on an ARB. Some physicians are. And like the ACE inhibitors, these drugs are fetotoxic. They can cause kidney problems in the fetus as well, so they're contraindicated in pregnancy. The last group of drugs that act on the renin-angiotensin-aldosterone system are the renin inhibitors, and there's really only one in this class. It's called aliskiren. It is a selective inhibitor, not of angiotensin-converting enzyme and not of the angiotensin receptor, but it's a selective inhibitor of renin. So it prevents renin from cleaving angiotensinogen into angiotensin 1. So it's acting earlier in this whole chain to block the renin-angiotensin-aldosterone system. It lowers blood pressure about as well as an ACE inhibitor or an ARB or a thiazide, so it's a good blood pressure lowering drug. It can be used in combination with ACE inhibitors and angiotensin receptor blockers and other antihypertensives. Unfortunately, because it's new, it tends to be more expensive, And it hasn't really been studied as well to prove that it has positive outcome effects on things like stroke and CHF and MI. So it may be shown down the road that it is beneficial in those areas, but it hasn't been proven at this point. The adverse effects of aliskiren include diarrhea, especially at very high doses. It can cause some cough, it can cause some angioedema, but less likely to do so than the ACE inhibitors. It can cause hyperkalemia, it can cause hyperuricemia and therefore gout, and it too is contraindicated in pregnancy.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
What enzyme converts angiotensinogen to angiotensin 1? Renin. What enzyme converts angiotensin 1 to angiotensin 2? Angiotensin converting enzyme. What is the main action of angiotensin 2? Vasoconstriction and secretion of aldosterone. So blocking the action of angiotensin 2 will lower blood pressure. Who is driving this camera? You? Back up! Pay attention! Point the camera where I'm working and try to anticipate where I'm going to want it next. Is that so hard?
So let's go through the answers to quick review 2. Number 1, a 50-year-old white male with diabetes, coronary artery disease, and hypertension comes to your clinic to establish care as a new patient. What medication should this patient be taking? So this is referring back to something we talked about in the first part of the lecture. What are your major considerations for diseases? So this patient, major consideration, coronary artery disease. They got to be on a beta blocker, and they got to be on either an ACE inhibitor or an ARB. Also considerations because of their diabetes. Another reason why they need to be on an ACE inhibitor or ARB to reduce the progression of the diabetic nephropathy, reduce progression of proteinuria. So 2 reasons why you need to be on ACE inhibitor and ARB, and 1 reason to be on the beta blocker. So in this case, even though beta blockers might cause some problems in diabetic patients and may not be the initial drug of choice, this patient has coronary artery disease. It's a major consideration. So this patient definitely needs to be on a beta blocker. Now, what if the combination of these drugs is not enough? You need additional blood pressure control. You can either increase the dose of those medications to improve control, or you can add a third agent such as hydrochlorothiazide. And number 2, what are the cardioprotective beta blockers? Not all beta blockers are built the same. All right, so you got your beta 1 beta blockers, and you have your non-selective beta blockers. You also have beta blockers that are cardioprotective. In other words, they reduce the incidence of the recurrence of coronary artery disease. And then you have beta blockers that don't do that. So if you have a patient with coronary artery disease, the only 2 beta blockers you should be using in those patients are metoprolol, whether it's short-acting metoprolol or long-acting metoprolol, or carvedilol is the other drug that you can use. So if you have a patient with a history of coronary artery disease that comes to your clinic with atenolol for control of their blood pressure, take them off the atenolol and put them on either metoprolol or carvedilol. Number 3, which 2 beta blockers function not only as beta antagonists but also as alpha antagonists? So these 2 are labetalol and carvedilol. Labetalol and carvedilol. And one way that you can remember this is all of your beta blockers end in the suffix OLOL, right? Except these 2. Labetalol ends in ALOL and carvedilol ends in ILOL. So they are unique in their spelling. They are also unique in that they have alpha-1 antagonistic effects, which is going to reduce blood pressure a little bit more than just a regular beta blocker. Also, a couple other unique things about labetalol. We said labetalol can be used in black patients. So in general, beta blockers are not great drugs for black patients, but labetalol is the one exception. All right, so moving on. Number 4, why are thiazide diuretics commonly used in combination with ACE inhibitors or ARBs? This combination is going to help reduce the incidence of hyperkalemia. So to reduce hyperkalemia, the combination is commonly used. Number 5, patient with diabetic renal disease is started on an ACE inhibitor, but then develops cough as a side effect. To what class of medication should this patient be switched? This is such a common test question. You got to know the answer to this one. This is an ARB, an angiotensin receptor blocker, because it's not going to have that cough side effect in general. Sometimes yes, but very rarely. So in general, if you have a patient on an ACE inhibitor that develops a cough because bradykinin is being increased, because you're inhibiting the breakdown of bradykinin by inhibiting that ACE enzyme, you can switch the patient to an ARB, and then the ACE enzyme is going to continue to break down bradykinin, so you don't have that bradykinin increase with angiotensin receptor blockers. But both ACE inhibitors and ARBs are going to offer the renal protection in your diabetic patient. Number 6, a patient with recently diagnosed hypertension was started on 25 milligrams of hydrochlorothiazide 3 months ago, now returns for follow-up. Blood pressure measured at home and in clinic is consistently higher than 140/90. Which second agent should be started on this patient with no other comorbidities? So, one thing I want to point out here is specifically in this question, Sim, we mentioned that the patient is measuring their blood pressure at home. Make sure you do this for your patients. It shouldn't be the case that the only thing you're treating is the blood pressure that you take in clinic. This may be referred to something as white coat syndrome. It may be that the patient is nervous about being in your clinic today, and that's raising his blood pressure. So if the patient is having normal blood pressures at the drugstores or at home, but then has high blood pressure in the clinic, that is probably something you don't need to treat because it's the scenario. It's the white coat syndrome. All right, so it's preferred to treat the patients outside of the clinic blood pressures rather than in the clinic blood pressures. But a common second drug after your hydrochlorothiazide are ACE inhibitors. So ACE inhibitors would usually be the second line drug category. Number 7, what is the problem with using propranolol in the setting of a patient with pheochromocytoma? So just a little background on what pheochromocytoma is. Pheochromocytoma is an adrenal medullary tumor in adults. So your adrenal glands, they make epinephrine and norepinephrine, and so you can imagine an adrenal tumor is going to make these hormones, and as a result, it's going to raise your blood pressure. And so if you give propranolol to these patients, you're going to reduce the heart rate because norepinephrine and epinephrine are going to raise your heart rate. So the benefit of the propranolol is it'll lower your heart rate back into normal range. However, if you think back to what your adrenergic receptors do, you have your alpha-1 receptors. When you stimulate them with epinephrine and norepinephrine, that causes vasoconstriction. But what happens when you stimulate those vessels with beta-2 stimulation? Beta-2 stimulation causes vasodilation. All right, so when you put epinephrine or an adrenergic agent into a system, you're going to have alpha-1 vasoconstriction stimulated and beta-2 vasodilation. Now at high doses of epinephrine and norepinephrine, the alpha-1 vasoconstriction is going to overpower the beta-2 vasodilation. So as a result, in a pheochromocytoma, with excess epinephrine, you're going to have vasoconstriction. But it's going to be balanced somewhat by beta-2 vasodilation. If you give a patient propranolol, you're going to get rid of the beta-2 vasodilation, and the result is you're going to unmask a solo alpha-1 vasoconstriction. So in the setting of a pheochromocytoma, if you add propranolol, not only is blood pressure going to be high because of the pheochromocytoma, it's going to go even higher because you get rid of any beta-2 vasodilation that may be around, and all you're left with is alpha-1 vasoconstriction. So can you give an alpha blocker to counteract that? Yeah, you can give an alpha blocker with a beta blocker, and that's going to have a much better effect than the beta blocker would by itself. Number 8, what effect does phenoxybenzamine have on the treatment of pheochromocytoma? So phenoxybenzamine is an irreversible peripheral alpha antagonist. So so you're going to get rid of that alpha-1 vasoconstriction. So as a result, the vasoconstriction is going to be relieved, and it's going to lower your blood pressure back into a normal range. So phenoxybenzamine is a drug that you're going to see used in the treatment of pheochromocytoma.
So those drugs we've just been talking about, the diuretics, especially the thiazide diuretics, the beta blockers, the ACE inhibitors, and the ARBs, are really your most common first-line drugs for the treatment of hypertension. Now we're going to move into some drugs that might be used first line, but are more often reserved for second-line use if a patient's not responding fully to the first drug and you need to add something. The first of these are the calcium channel blockers. And there are a lot of different classes of calcium channel blockers, but basically we divide them into dihydropyridines and non-dihydropyridines. The dihydropyridine calcium channel blockers include nifedipine, amlodipine, felodipine, isradipine, nicardipine, and nisoldipine. Now there are a lot more of these actually. There are a couple dozen calcium channel blockers. Not all of them are available in the United States. In general, the dihydropyridines have a much greater affinity for calcium channels in the vasculature than they do in the heart. The non-dihydropyridines include a drug called verapamil. Verapamil is much more selective for cardiac calcium channels. It has some effect on vascular calcium channels. And then the other non-dihydropyridine you need to know is diltiazem. And it has an action that's sort of halfway between the dihydropyridines and verapamil. It acts some on the vascular calcium channels and some on the cardiac calcium channels. So intracellular calcium plays an important role in muscle contraction and maintaining the tone of the vascular smooth muscle and in contraction of the myocardium. The way this works is calcium enters the cells through a voltage-gated calcium channel, and that influx of calcium triggers the release of stored intracellular calcium from the mitochondria and the sarcoplasmic reticulum. And it's that release of stored calcium that triggers contraction of the muscle. So the calcium channel blockers act by binding to that voltage-gated calcium channel to prevent that initial influx of calcium so that the stored calcium stays stored, and therefore you don't get contraction of the muscle, and you actually have relaxation of the muscle. A lot of these calcium channel blockers dilate primarily arterial supply, but they can also dilate the veins. In general, black patients respond very well to calcium channel blockers in terms of hypertension. They're useful in patients who have asthma, diabetes, and angina. So if you have asthma or diabetes, you might not want to give a beta blocker. If you have angina, you want to dilate some blood vessels, calcium channel blockers will do that. So it's a good drug for that. They are used in tachyarrhythmia, specifically atrial fibrillation. Again, we're talking about the non-dihydropyridine drugs, the verapamil and diltiazem, being used to slow the heart rate in atrial fibrillation. The dihydropyridines are no good for that whatsoever. Sometimes we use these for migraine prophylaxis and other headache syndromes, such as cluster headaches. Sometimes we'll use the dihydropyridines or verapamil, a non-dihydropyridine, in conditions like Raynaud's phenomenon, where you have vasospasm. In terms of pharmacokinetics, these are all oral drugs, but some of them could be given IV, specifically diltiazem, verapamil, and nicardipine. Most of these have pretty short half-lives, from 3 to 8 hours, so sometimes they have to be given 2 or even 3 times a day. A lot of them have sustained release formulations available, so you can give them once a day. One drug, one of the dihydropyridines, amlodipine, has a very long half-life, more than 24 hours. So it does not require a sustained release formula. It can be given once a day. Verapamil is extensively metabolized by the liver, so if you're going to use it in a patient with liver disease, you want to use extreme caution. In terms of adverse effects, calcium channel blockers cause vasodilation, so they can cause headache. They can cause hypotension and therefore some dizziness and fatigue. These effects are much more common with the dihydropyridines than with the non-dihydropyridines. The non-dihydropyridines, however, have a lot of effect on the heart. So they block cardiac calcium channels, and they will have negative inotropic effects. So you need to avoid these in patients with congestive heart failure. All of the calcium channel blockers, dihydropyridines and non-dihydropyridines alike, can cause fluid retention and edema, which could be a real problem in patients with congestive heart failure. So in general, all of the calcium channel blockers are somewhat dangerous to give to a patient with congestive heart failure. The non-dihydropyridines, verapamil, and diltiazem can cause bradycardia. The dihydropyridines don't cause any bradycardia. They don't cause any slowing of the heart rate whatsoever. So unfortunately, when you dilate the blood vessels, you dilate the peripheral vasculature, the heart may compensate and you may get a reflex tachycardia. You don't see that with the non-dihydropyridines. Calcium channel blockers can cause constipation. They also cause a condition called gingival hyperplasia, where you have hyperplasia of the gums around the teeth. And these patients can have really excessive gum tissue, it sometimes has to be treated surgically. Usually if you just stop the drug, the gingival hyperplasia will self-resolve. The next group of drugs are the alpha blockers, the alpha adrenoreceptor blocking agents. And these drugs include prazosin, doxazosin, and terazosin. Now, these are competitive antagonists of the alpha-1 receptors. They relax both arterial smooth muscle and venous smooth muscle, and therefore they're going to decrease peripheral vascular resistance and decrease arterial blood pressure. They cause minimal changes in cardiac output, which is good. They cause minimal changes in renal blood flow and GFR, which is good. They're used generally to treat mild to moderate hypertension. They're sometimes used in combination with propranolol or other beta blockers, or sometimes a diuretic to get an additive effect. So you usually don't use an alpha blocker by itself. You can get reflex tachycardia from alpha blockers, so you often have to give a beta blocker to prevent that reflex tachycardia. They're really rarely used, and one of the findings of the All-Hat study was that alpha blockers may be a little more dangerous and a little less effective at treating hypertension and preventing some of those outcomes such as stroke and MI than some of those other drugs which were a little safer. So that's why we use it second and third line. These drugs are also used to treat benign prostatic hypertrophy. So if you have a patient with BPH and hypertension, you might want to consider an alpha blocker for first-line therapy in that patient to treat both conditions with one drug. There's another alpha blocker called tamsulosin, which is more selective for prostate muscle, and it's used exclusively for BPH and not for blood pressure. The adverse effects of the alpha blockers include reflex tachycardia, as I mentioned. Also, you can get first-dose syncope, so you get a dramatic drop in blood pressure and the patient has syncope. They pass out when you give the first dose, so you need to be aware of that. They don't cause long-term tachycardia, which is useful to know. You can get postural hypotension even after that first dose syncope has passed. You can still get some postural hypotension where the patient is lying down or sitting for long periods of time, stands up quickly, and the blood pressure drops and they feel lightheaded or dizzy or woozy. So you need to be aware of that and warn the patient about that. These drugs also can cause some salt and water retention, so that's why we sometimes give a diuretic with it to counteract that salt and water retention. And because of salt and water retention, you can see an increased rate of congestive heart failure in patients that are taking doxazosin alone compared to those taking a thiazide diuretic alone. The next group of drugs are centrally acting adrenergic drugs, including clonidine and alpha-methodopa. The first drug is clonidine, and it has an interesting mechanism of action. It's an alpha-2 agonist. Unlike the alpha-1 blockers and the beta blockers, this is an agonist of the alpha-2 receptors. You remember on your adrenergic neuron releasing norepinephrine, on the presynaptic nerve terminal, there were alpha-2 receptors, and norepinephrine would be released, and then it would agonize those alpha-2 receptors, and that would inhibit further norepinephrine release. So clonidine is an agonist of those same alpha-2 receptors in the brain, and therefore it's going to diminish central adrenergic outflow. You're going to have less adrenergic output. Because of this, it doesn't decrease renal blood flow. It doesn't decrease GFR. It's used primarily for hypertension that has not responded to other drugs. Usually 2 or 3 drugs have failed. It's often used in the treatment of hypertension that's complicated by renal disease because it's not going to reduce renal circulation whatsoever. Unfortunately, it can cause sodium retention and water retention, so it may have to be given along with a diuretic. It is well absorbed after oral administration. It has a pretty long half-life, but for one reason or another, it has to be dosed every 8 to 12 hours or you get rebound hypertension. The drug kind of wears off and the blood pressure shoots way back up. So you have to give this drug 2 or 3 times a day. The drug is excreted by the kidney. The adverse effects, it can cause hypotension. It can cause rebound hypertension, as we mentioned. It can cause sedation and dizziness. It can cause some constipation. It can also cause dry mouth and drying of the nasal mucosa. So it can be a pretty unpleasant sensation if you take this drug. The other centrally acting adrenergic drug to discuss is alpha-methyl-dopa, or sometimes just called methyl-dopa. This is an analog of dopa, which, as you remember, is taken up into the central nervous system, converted to dopamine, which is then converted to norepinephrine. So methyl-dopa is taken up into the central nervous system, and it's converted down the same pathway to methyl-norepinephrine. Methylnorepinephrine is an agonist of the same alpha-2 receptors on the presynaptic nerve terminal, so it's going to also inhibit sympathetic discharge and reduce blood pressure in the same way. It reduces total peripheral resistance, it decreases blood pressure, but it doesn't affect cardiac output, it doesn't affect blood flow to the kidneys and other organs. It is most commonly used in patients who are pregnant who also have hypertension. So if you have a patient who was hypertensive before she got pregnant and now she needs something to treat her hypertension while she's pregnant, you can put her on alpha-methyl-dopa. Also, patients who have pregnancy-induced hypertension may be treated with alpha-methyl-dopa. There are 4 drugs that we commonly use to treat hypertension in pregnancy, and they're important to know. The 4 drugs are methyl-dopa, hydralazine, which we'll see in just a moment, nifedipine, which is a calcium channel blocker, and I've sometimes seen obstetricians use other calcium channel blockers, and then labetalol, which is one of the alpha-beta blockers we just talked about. Alpha-methyl-dopa is also useful in patients with renal disease because, as I said, it doesn't diminish renal circulation. And then the adverse effects are similar to clonidine. It can cause sedation and drowsiness and so forth. It doesn't seem to cause the rebound hypertension that clonidine does. The last group of drugs we'll talk about in the routine day-to-day treatment of hypertension are vasodilators, specifically hydralazine and minoxidil. Now, these are drugs that relax the vascular smooth muscle, which decreases resistance and decreases blood pressure. They often produce a reflex stimulation of the heart, so the blood pressure is lower, the heart is going to compensate for that increased vascular resistance by increasing cardiac output. It's going to have an increased heart rate, increased contractility. So this can be dangerous in patients who have angina because you're increasing myocardial oxygen demand. It can be dangerous in patients who have heart failure because they can't increase their contractility much. It can also be dangerous in patients who are prone to MI because you're increasing myocardial oxygen demand and you can actually cause an MI. These drugs also increase plasma renin concentration, which acts to increase sodium and water retention because the body is sensing a lower blood pressure, it's sensing the vasodilation, so you're going to increase renin and therefore retain sodium and retain water. So the first drug is hydralazine. Its exact mechanism of action is not well understood. You look it up in 4 different books, you're going to get 4 different answers as to how it works. It may cause release of nitric oxide, which is a natural vasodilator. Nitric oxide works via increasing cyclic GMP. Hydralazine may itself increase cyclic GMP and therefore cause smooth muscle relaxation and vasodilation. Hydralazine may affect inositol triphosphate and reduce calcium influx, which causes less contraction of the vascular smooth muscle. As we mentioned, this is a vasodilator, and hydralazine primarily dilates arteries and arterioles. It is used to treat moderately severe hypertension, sometimes used with a beta blocker to balance that reflex tachycardia we talked about, and a diuretic to balance that sodium retention we talked about. And as we mentioned, hydralazine is one of those drugs that can be used as monotherapy to treat pregnant women with hypertension. The adverse effects of hydralazine, as we mentioned, vasodilators tend to cause headache. They can cause reflex tachycardia. They can cause precipitation of angina. Hydralazine can cause nausea and sweating. It can cause fluid retention. And hydralazine has a unique adverse effect which you need to know. It can cause a lupus-like syndrome, which is reversible. When you stop the hydralazine, this goes away. But somehow, hydralazine triggers the development of antihistone antibodies that can develop into a lupus-like syndrome. There are 5 drugs that cause a similar lupus-like syndrome, and you need to know all these. The mnemonic is SHIP, S-H-I-P-P. And the drugs are sulfasalazine, hydralazine, isoniazid, procainamide, and phenytoin. The other vasodilator is minoxidil. It works in a different way. It opens up potassium channels and causes potassium to leave the cells, which causes hyperpolarization of the cells, so the cells are less likely to contract. The vascular smooth muscle is less likely to contract. And it acts to dilate arterioles, but not venules. It's an oral drug. It's used to treat severe hypertension that's not responding to other therapy. Minoxidil is a very, very good blood pressure drug. It's just not really a first-line drug. It's usually used in patients who are refractory to other treatment. Minoxidil is also used topically to treat male pattern baldness. You've heard of the drug Rogaine. Well, Rogaine is minoxidil. The adverse effects, again, it can cause reflex tachycardia, it can cause sodium and water retention and volume overload, so it may be dangerous in patients who have congestive heart failure, and it can cause hypertrichosis or growth of body hair. So those are all the drugs used to treat routine day-to-day hypertension on an outpatient basis. Next, let's talk about drugs used to treat hypertensive emergency. So by definition, hypertensive emergency is a diastolic blood pressure greater than 150 with a systolic blood pressure greater than 210 in an otherwise healthy person, or diastolic blood pressure greater than 130 in any individual with pre-existing complications such as encephalopathy, cerebral hemorrhage, left ventricular failure, aortic stenosis. So there are several drugs that are routinely used to treat malignant hypertension or hypertensive emergency, including sodium nitroprusside, labetalol. These are two of the most common, but you see listed several others: nifedipine, which is a calcium channel blocker, clonidine, hydralazine, nitroglycerin, ACE inhibitors, and on and on. The point is not to memorize this list, but rather you can use almost any antihypertensive drug to treat a hypertensive emergency. But let's talk about the two most common drugs and then a couple of others. The first one is sodium nitroprusside. This is a nitrate drug. Nitrates are discussed more extensively in Chapter 18 on anti-anginal drugs. Nitrates are converted to nitrite ions, which is then converted to nitric oxide. And as I just mentioned, nitric oxide activates guanylyl cyclase and increases cyclic GMP, and ultimately leads to dephosphorylation of the myosin light chain, and that causes vascular smooth muscle relaxation. So these are vasodilators, kind of like some of the other vasodilators we've talked about. Nitroprusside, unlike hydralazine, for instance, acts equally on veins and arteries. So it's going to dilate the vasculature throughout the body. It has very little effect outside the vascular system. So even though it causes smooth muscle relaxation, it's really only causing smooth muscle relaxation in the blood vessels. It's used to reduce blood pressure in any kind of patient who has hypertensive emergency. It doesn't matter what the cause of that hypertension is. It's given intravenously, and it's light sensitive, so you'll sometimes see this bag surrounded by like aluminum foil or a coating on the bag that is opaque to light. So you should be aware that the nitroprusside is going to be degraded in the light. Oral nitroprusside is poisonous because it is hydrolyzed to cyanide. So nitroprusside can be a cause of cyanide poisoning, which is kind of unusual, and you should file that away. It is metabolized very rapidly. It has a half-life of only 1 or 2 minutes, so it has to be given via constant, continuous IV infusion. As I mentioned, it's metabolized to produce cyanide. Cyanide toxicity is very rare, but you're going to treat cyanide toxicity with sodium thiosulfate, which will produce thiocyanate, which is less toxic and can be excreted by the kidneys. The adverse effects of sodium nitroprusside: it can cause reflex tachycardia because it's a potent vasodilator. If you give too much of it, you can cause hypotension. Luckily, it wears off quickly, so you can literally dial the patient's blood pressure by adjusting the dose of nitroprusside. Nitrates very commonly cause headache, so you can get a headache in a patient who has this, who's on this drug. And then, as discussed, it can cause cyanide toxicity. The other commonly used antihypertensive drug for malignant hypertension is labetalol, and as we mentioned, this is an alpha and beta blocker. It should not cause reflex tachycardia because it does have some beta blockade. It is given as an IV bolus or as an IV infusion in hypertensive emergencies. There are oral tablets available, but those are not usually used for hypertensive emergency. You usually reserve that for patients who are going to be on labetalol for other reasons, such as pregnancy-induced hypertension. It has a much longer half-life than sodium nitroprusside, but that means you can't titrate it as quickly. Its half-life is 5 to 6 hours, so you can't just shut it off and watch the blood pressure come back up as you can with sodium nitroprusside. The adverse effects: it does block beta-2 receptors, so it can cause some bronchospasm, and it can cause bradycardia through the beta-1 blockade. Another drug sometimes used for the treatment of hypertensive emergency is phenoldiprem. This is very rarely used. I'll be honest, I've never seen it used. It's an agonist of peripheral dopamine 1 receptors. It's given as an IV infusion, and it does maintain renal perfusion while it's lowering blood pressure, so that's worth knowing. It's not commonly used, although it can be safely used in any hypertensive emergency. It's particularly beneficial in patients who have renal insufficiency. The adverse effects, it can cause hypotension, it can cause reflex tachycardia, it can cause some flushing, it can cause headache, angina, and it can cause increased intraocular pressure, so you don't want to give it to patients who have glaucoma. And then the last drug to mention is nicardipine. It's a calcium channel blocker that can be given as an IV infusion. Unfortunately, it also has a long half-life of about 8 hours, so you cannot titrate it anywhere nearly as well as you can nitroprusside.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. Okay, now let's go through the answers to Quick Quiz 3. Number 1, which calcium channel blocker has the highest incidence of causing constipation? So as calcium channel blockers relax smooth muscles, think about where do you have smooth muscles? You have it in your vasculature, which is why calcium channel blockers reduce your blood pressure, but you also have smooth muscles in your gut. And if your gut can't contract, then you're not going to have peristalsis, you're going to have constipation, right? So that's why calcium channel blockers cause constipation. Which calcium channel blocker in particular has the highest incidence of this? It's verapamil. Number 2, what antihypertensive might give you a positive Coombs test, indicating there might be a potential for hemolytic anemia? This is methyl-dopa. So it's just one of the high-yield little things to know about methyl-dopa. Number 3, why might a vasodilator, such as hydralazine, not be a good choice as a single antihypertensive agent? Vasodilators can cause a reflex tachycardia, right? Think about this. You vasodilate, you're not getting enough preload back to your heart, or maybe you're not getting enough blood flow to your end organs because you're vasodilating and distributing that blood flow. So as a result, you're going to be lowering blood pressure, and your heart's going to respond by increasing its heart rate, causing a reflexive tachycardia because the blood pressure is being lowered. So your vasodilators cause a reflexive tachycardia, and as a result also of lowering the blood pressure, they're going to activate the renin-angiotensin-aldosterone system. So in this case, adding a beta blocker to take care of the reflexive tachycardia could be helpful. So you're going to lower blood pressure with your hydralazine and not have the reflexive tachycardia because you have the beta blocker on board. So that's one option. And the other option is to add a diuretic to counteract the activation of the renin-angiotensin-aldosterone system. So commonly you're going to see beta blockers given with hydralazine and or a diuretic given with hydralazine. Number 4, which antihypertensives act on only arterial pressure? So arterial pressure affects the afterload. So another way of restating this question is which two antihypertensives act only by affecting afterload? These are hydralazine and diazoxide. Diazoxide is not an FDA-approved drug for the treatment of hypertension here in the U.S. It can be given in hypertensive emergencies, so you might see it referred to in that way in some textbooks. But one interesting thing about diazoxide is sometimes it's given to treat hypoglycemia due to excess insulin. So in general, the two antihypertensives that can act on arterial pressure only are hydralazine and diazoxide. Number 5, which antihypertensive drug category is associated with first dose orthostatic hypotension? You got to know this one. These are your alpha blockers ending in zosyn. Terazosin, doxazosin, prazosin, your zosyn drugs. Number 6, which antihypertensive drugs are known for causing reflex tachycardia? All of your vasodilators. If you have vasodilation, you're going to get a reflexive tachycardia. So which drugs cause vasodilation? Either in the arterioles or in the venules. This would be your nitrates, your dihydropyridine calcium channel blockers, sodium nitroprusside, and minoxidil. All these drugs are vasodilators, right? What about verapamil? It's not a vasodilator, right? Verapamil is a calcium channel blocker that is not a dihydropyridine. So it's actually going to lower heart rate because it works primarily at the heart. It's not going to cause reflex tachycardia. But your dihydropyridine calcium channel blockers do cause a reflexive tachycardia. So I like to think of calcium channel blockers in those two main things, two main categories. You got your dihydropyridines that act on smooth muscle, causing reflexive tachycardia, and then you have your verapamil, which acts at the heart and actually causes bradycardia. Number 7, which antihypertensive is known for severe rebound hypertension upon discontinuation? This is clonidine. Clonidine is not the preferred antihypertensive for most any patient. It has to be taken 3 times a day, and if you miss a dose, guess what happens? Your blood pressure shoots right back up. So it's not commonly used. However, it is sometimes used by nephrologists because it tends to work well for renal patients. Number 8, for what other purpose is clonidine commonly used that is unrelated to its use in treating hypertension? This is kind of a strange thing, but clonidine is commonly used in the treatment of ADHD, attention deficit hyperactivity disorder. So especially in helping these children to sleep. So if you have a patient on a stimulant medication during the day and for their ADHD and they're having a hard time sleeping, some clonidine at night is commonly used to help these patients. And the last one, number 9, what medications or medication combinations are commonly used to reduce both afterload and preload in patients with heart disease? So you have several different options here. ACE inhibitors will do this. Angiotensin receptor blockers will do this. Sodium nitroprusside, we said, can do this, but you're not going to give sodium nitroprusside long-term because of the risk of cyanide toxicity, right? It's just a short-term drug. And then another long-term combination that can be used in patients with heart disease to reduce afterload and preload is hydralazine, which is going to affect the afterload, in combination with a nitrate, which is going to affect the preload. We also mentioned that clonidine can affect both afterload and preload, but it is not used in the setting of heart disease. So this is not, it wouldn't be used in this scenario, although it does reduce both afterload and preload. Okay, so now's a good time to pause the video and complete your in-session quiz, then restart the video and we'll go through the quiz together.
Hello, I'm Dr. Chris Lewis. I'm one of the DIT Chief Educators. Today we're doing the in-session quiz for antihypertensive medications. Let's get started. What side effects are commonly associated with beta blockers? Well, there's quite a few of them. Bradycardia, there are CNS effects, meaning lethargy and fatigue, hypotension, the blood pressure going too low, decreased libido and impotence or erectile dysfunction, and poor exercise tolerance. For most patients, what would be the first antihypertensive drug? Well, that would be the thiazide diuretics, and those include chlorthalidone and hydrochlorothiazide. Which antihypertensives are safe to use in pregnancy? Methyldopa, hydralazine, nifedipine. There are other dihydropyridine calcium channel blockers that are also used, and labetalol. Which antihypertensive drugs can increase uric acid and increase the risk of gout? Well, this includes the diuretics, thiazides, loop diuretics, and potassium-sparing diuretics, and also includes the renin inhibitor, aliskiren. What side effect is commonly seen following abrupt withdrawal of clonidine? Well, this is rebound hypertension. While on an ACE inhibitor, a patient develops a cough. What is a good replacement drug, and why doesn't it have the same side effect? Well, most of the time people on the ACE inhibitor with the cough, it's due to increased bradykinin. So you want a medication that mimics the same effect of the ACE inhibitor but doesn't increase bradykinin, and those are the angiotensin receptor blockers, or the ARBs. Which antihypertensive class or drug fits the following side effect? First dose orthostatic hypotension. Well, this is the alpha blockers, prazosin, doxazosin, and terazosin. Ototoxic, especially when combined with aminoglycosides. Well, these are the loop diuretics, furosemide and torsemide. Hypertrichosis. This is associated with minoxidil. Hyperkalemia. Well, obviously the potassium-sparing diuretics, spironolactone, triamterene, and amiloride. Cyanide toxicity, and this is sodium nitroprusside. Dry mouth, sedation, severe rebound hypertension, and this is clonidine. Bradycardia, impotence, asthma exacerbation. These are the beta blockers, and more specifically with the asthma exacerbation with the nonspecific beta blockers. Reflex tachycardia. Well, any of the vasodilators will do this, including the dihydropyrimidine calcium channel blockers, hydralazine, and nitrates. Cough. ACE inhibitors. You might want to avoid, in patients with a sulfa allergy, the thiazide diuretics and the loop diuretics. And angioedema can be associated with ACE inhibitors and sometimes with the angiotensin receptor blockers. Hypercalcemia and hypokalemia are found with the thiazide diuretics. Which antihypertensive drug can cause a reversible lupus-like syndrome at high doses? Well, this is hydralazine. Which antihypertensive drug might be a good choice for patients with diabetic nephropathy, and why? Well, the ACE inhibitors and sometimes the ARBs, angiotensin receptor blockers. These reduce proteinuria and slow progression of diabetic nephropathy. In a patient with a history of coronary artery disease, already taking a thiazide diuretic and an ACE inhibitor, what class of antihypertensive drug would be a good choice for add-on therapy? Well, unless it's contraindicated, all post-MI patients should be on a beta blocker, as these have been shown to reduce morbidity and mortality and reduce the incidence of recurrent myocardial infarction. And that's the end of your antihypertensive in-session quiz. Thank you.